Welcome to ATCM, the Emergency Medicine channel. Today let us discuss about deep venous thrombosis or DVT. DVT and pulmonary embolism both are venous thrombosis. They are the most common presentation of venous thrombosis. So venous thrombosis can be due to stasis of blood, hypercoagulability, or venous endothelial damage. These are the three important factors of venous thrombosis. We can see various causes for venous thrombosis: acquired causes or inherited causes. Acquired causes are obesity, varicose veins, trauma to veins, infections, severe dehydration, myeloproliferative disorders like polycythemia, prolonged immobility, post-surgical time. Same immobility is the reason for that. Cardiac failure, malignancy, nephrotic syndrome. These are the common causes for venous stasis and thrombosis. Other conditions are inherited hypercoagulable states, antithrombin 3 deficiency, protein C or protein S deficiency. Protein C and protein S deficiency can be acquired also. Factor V laden mutation, prothrombin 20210A gene mutation, dysfibrinogenemia, antiphospholipid syndrome, it may be a part of SLE, hyperhomocystinemia, it may be due to vitamin B12 folic acid deficiency. So these are the common causes for venous thrombosis, including DVT and pulmonary embolism. Other important causes are like malignancy can sometimes produce venous thrombosis. It can produce cancer-related procoagulant state or immune-mediated thrombosis. Pregnancy can present with venous thrombosis. Pregnancy, when it is associated with SLE, have higher possibility of venous thrombosis. Nephrotic syndrome is another important cause for venous thrombosis. That is because of the loss of many anticoagulant proteins like plasma antithrombin through the kidneys. So these are the important causes, but clinically prolonged bed rest, that is the most important cause for deep vein thrombosis, especially post-surgical time, prolonged travel. All these things are most common things. Other causes for venous thrombosis, one important cause is not very common, but it is heparin induced thrombocytopenia or HIT. It is very common with conventional heparin therapy, not with low molecular weight heparin, but rarely it can be associated with low molecular weight heparin also. Hypergammaglobulinemia can also be associated with DVT, like multiple myeloma can present with thrombosis. There are a lot of other undetectable causes also can produce DVT. Unprovocating reasons. Without any major reasons, patient can have DVT. Now we can see the clinical findings. Deep vein thrombosis normally present with severe pain and limb swelling, especially calf muscle swelling is very common. The close differential diagnosis is cellulitis. In many patients, patient can have cellulitis, but patient can have features of DVT. We'll have to do a Doppler study and rule out DVT. Pain can occur during dorsiflexion of foot, that is called as Homan sign. Tenderness can be there on that area. Swelling, redness, warmthness, but tenderness should not be elicited in this type of patients, because while testing tenderness, when we squeeze the muscles, it can dislodge the thrombus from there and can lead to pulmonary embolism. One of the most common complications of deep vein thrombosis is pulmonary embolism. If a patient who is having deep vein thrombosis suddenly present with severe cough, chest pain, left ventricular failure, hemoptysis, we should suspect pulmonary embolism. So these are the common clinical findings. But many patients with proximal DVT popliteal, femoral, iliac veins can also present with thigh pain or upper part of the leg pain. Some patients can have upper limb venous thrombosis also, especially those who are having malignancies, so can present with upper limb thrombosis also. Now we have a scoring system to make a probable diagnosis of DVT. This is called as Wells score. There are multiple scoring systems are available. This is one of the most commonly used scoring system. From this scoring system, we can have three important diagnostic scores. One is high probability, 3 or more, moderate probability, 1 to 2, low probability, 0 or less. Modified Wells score is given in the lower part of this same chart. DVT likely, 2 or more scores. DVT unlikely, 1 or less score. So this is pretest probability score for DVT. This is called as Wells score. The last part is given as modified Wells score. The investigations we will see now for deep vein thrombosis. Whenever there is lower limb swelling, we can ask for a blood count, CBC, complete blood count. In patients who is having cellulitis, you can see high WBC count. And patients with polycythemia can have DVT. D-dimer is one important test. It has got a negative predictive value. If D-dimer is not elevated, we can rule out DVT or pulmonary embolism. If D-dimer is positive, there are a lot of other causes for D-dimer elevation. So it is not a good test to diagnose it, but if it is negative, we can probably rule out venous thrombosis. Doppler study and venography. Doppler study of vein is very, very important in emergency room. We can pick up DVT very fast. Ultrasound abdomen should be done in a patient with DVT and suspected malignancy. If there is no other cause, especially in elderly individuals, we'll have to do ultrasound abdomen, ultrasound pelvis, ultrasound breast, ultrasound axilla to see any malignancies or lymph node infiltrations. Chest X-ray can be done to rule out lung malignancies. Procoagulant workup like protein C, protein S, antithrombin 3, all these things can be done in some patients, not in all patients. When there is no major cause is clinically detected for a DVT, then we can go for procoagulant workup. In pulmonary embolism, echo can be done, chest CT, pulmonary angiogram, CT pulmonary angiogram, ventilation-perfusion scan. These are the common investigation can be asked for pulmonary embolism. But remember, in DVT, the most important investigation is always a Doppler study of that vein. That is very, very important. Compression ultrasound is one test which can be done to see whether the veins are compressible or not. We know that when there is a obstruction in the veins, veins will not be compressible. So non-compressibility of a vein with clinical findings, we can make a diagnosis of deep vein thrombosis by ultrasound. Now once we make a diagnosis of deep vein thrombosis by clinical findings, Doppler study and ultrasound compressibility, we will have to start the patient on anticoagulation. We can start anticoagulation like heparin or low molecular weight heparin with oral anticoagulation with warfarin or some other drugs. Anticoagulation is indicated for all patients with proximal DVT like popliteal, femoral, iliac vein and selected case of distal DVT, calf vein thrombosis. Anticoagulations like heparin should be given for first 10 days, then we can continue with warfarin. The most commonly used drug for anticoagulation is heparin. It acts as an anticoagulant by activating antithrombin 3, and accelerating the rate at which antithrombin inhibits clotting enzymes, particularly thrombin and factor Xa. Standard dose is 500 units. Loading dose can be given IV, then continuous infusion of 18 units per kg per hour. Loading dose can be 80 units per kg loading dose, then continue the infusion as 18 units per kg per hour. We'll have to monitor the APTT during heparin. APTT should be 46 to 70 seconds. Very rarely patient can develop heparin-induced thrombocytopenia, but bleeding tendencies are common with heparin. If the patient develops any complication, antidote for that heparin is protamine sulfate. Now, once we have a patient who is having DVT or pulmonary embolism, when we start on bolus dose, it is 80 units per kg bolus, then start infusion 18 units per kg per hour, and depending on APTT, we can adjust the dose according to this chart. So dose adjustment is very important, because some patients can develop prolonged APTT more than these levels. Then patient may develop clinical bleeding also. So we'll have to adjust the dose according to this chart. Now, alternative drugs for regular heparin is low molecular weight heparin. Here, one advantage is it is subcutaneous injection. It can be given as an OPD basis treatment, and no need to monitor the patient. That is very important. No need to monitor APTT. And heparin induced thrombocytopenia is very less. But the cost of low molecular weight heparin is comparing with regular heparin is very high. So we routinely use enoxaparin 1 mg or 100 units per kg BD. That is a dose. Other drugs are dalteparin, raviparin, nadroparin, parnaparin. These are the different types of low molecular weight heparins available in the market. Fondaparinux is factor Xa inhibitor. It's a synthetic analog of antithrombin binding pentasaccharide sequence. The drug is given at a dose of 2.5 to 5 mg once daily for prevention of venous thrombosis. The major side effect of fondaparinux is bleeding. There is no antidote for fondaparinux. So there is a problem of fondaparinux. It is costly. There is no antidote available at present for this drug. Comparing to heparin, protamine is available. Here there is no antidote, and it is costly also. Now, if the patient develops heparin-induced thrombocytopenia, it is better to stop the drug. Platelet transfusions are not indicated in heparin-induced thrombocytopenia. We should remember that. So we can switch to an alternative anticoagulation method, like other drugs can be tried in heparin-induced thrombocytopenia. Now, along with heparin, we have to start vitamin K antagonists like warfarin or acitonopramide. Warfarin should be started as a loading dose 10 mg per day initially itself, then taper down the dose according to the INR. That is very important. We should not start warfarin after heparin. Along with heparin, we have to start warfarin, continue warfarin, because warfarin peak action, it will take nearly 7 days. So we'll have to wait, and once we stop heparin, we can continue warfarin, and we have to monitor the INR. Whereas in heparin, we were monitoring APTT. Here we are monitoring PT, prothrombin time, and INR. So start with 10 mg per day, taper down the dose or slightly increase the dose. Most of the patients may require 7 to 10 mg of warfarin every day. Remember, when the patient is on warfarin, if we are starting any other drug, we have to check for the interactions. This is the most common mistake done by many practitioners. Without seeing the interactions, if we start some other medications, the effect of warfarin can sometimes increase or decrease depending on the drug. Usual maintenance dose for warfarin in DVT is 2 to 3. That is very, very important. We have to keep the INR in between 2 to 3. Dosage adjustment can be tried according to this chart when we are continuing warfarin. So if patient develops any risk of bleeding, we can treat vitamin K. Treat with vitamin K and fresh frozen plasma. So vitamin K is an antidote for warfarin. Rivaroxaban is factor 10A inhibitor. It's a direct oral anticoagulant. So it has got a lot of advantages when we compare with warfarin. Drug interactions are very, very minimal. So we no need to worry about drug interactions. The dose is 15 mg BD with food for 21 days, followed by 20 mg OD with food to be continued. Apixaban, dabigatran, these are other drugs which can be tried instead of warfarin. They are direct oral anticoagulants, not vitamin K antagonists. Now we will see the duration of anticoagulation in venous thrombosis. For DVT isolated to an upper limb or calf that has been triggered by a trauma or a surgery, 3 months. First episode of venous thrombosis with reversible risk factors like prolonged travel, oral contraceptive pills, hormone replacement therapy, minor surgery, proximal leg DVT, 6 to 12 months. DVT with malignancy, long term till primary problem is treated. Venous thrombosis with inherited hypercoagulable risk factors, patient has to take indefinitely, lifelong patient has to take the drug. Other management in emergency or emergency ICU, ambulation, that is very important. Early ambulation is safe in patients with acute DVT and should be encouraged as soon as possible. Thrombolytic therapy is not indicated in DVT, but patient who is having massive pulmonary embolism or very extensive life-threatening DVT, we can try thrombolytic therapy. Inferior vena cava filters are recommended in deep vein thrombosis. Either anticoagulation is contraindicated or malignancy induced venous thrombosis where the malignancy cannot be treated by routine treatment methods. Hyperhomocystinemia, the treatment is folic acid and B12. So that these are the treatment for hyperhomocystinemia induced venous thrombosis. So we have discussed about DVT and its clinical features. Most important investigations like ultrasound, Doppler, all these things, and treatment options like in emergency room we have to start immobilization, heparin or low molecular weight heparin, warfarin, or other drugs which can be used in DVT. Thank you.